And the focus will predominantly be on tricuspid valve disease in terms of looking at the anatomy, looking at the morphology of the tricuspid valve. This is echoing a little bit. It's just... You guys hear an echo on your end?
Yeah, there's some echoing going on.
Is it still there?
Can you say 1, 2, 3, 4?
1, 2, 3, 4.
A little bit. Yeah. Anyone can see if there's any other sort of like speaker turning on right now?
It's happening between your...
Yeah, but my mic and my speaker is off here.
Okay, everyone, please turn off your microphone, and that will highly appreciate. Okay, so do you want to just start from the very beginning for recording purposes?
Okay, sure, we'll start again here. So thank you very much for allowing me to be here to speak to you guys today. We're going to be talking about tricuspid valve disease. We'll focus on the tricuspid valve anatomy and then some of the basic views on transthoracic and TEE of the tricuspid valve, and to sort of help us look at this complex valve in a little bit more detail in terms of what we're looking at. And then we'll talk about the echo evaluation of tricuspid regurgitation, including the identification of different etiologies, some of the classic parameters that we use in terms of evaluation of tricuspid regurgitation, as well as the new but not so new grading system for tricuspid regurgitation severity. And then we'll spend a little bit of time, but not that much time, on tricuspid stenosis, kind of proportional to the amount of tricuspid stenosis that exists compared to the tricuspid regurg burden. So why is this important? Well, 75% of the population have at least mild tricuspid regurgitation, and 4% of the population have moderate or more tricuspid regurgitation. Recent studies that have come out but are not published yet have shown that the incidence of tricuspid regurgitation continues to increase, and that tricuspid regurgitation actually has a mortality of 40 to 70% at 1 to 4 years, if it's significant. And this is a parallel with what you would see with aortic stenosis. And for years, we've kind of paid a lot of attention to aortic stenosis, maybe because we had really great therapies for it as well. But now, in the realm of us having more and more therapies available for tricuspid regurgitation, we need to start paying more attention to this valve that used to be the forgotten valve. And then now, last week, Dr. Leung Poi presented the pulmonic valve. I think that's the new forgotten valve, because the tricuspid valve is the new thing of the hottest thing that's happening now, and no longer forgotten valve. But it's important also because the symptoms can sometimes be vague. So patients will present sometimes with impaired functional capacity, sometimes with exertional dyspnea, but with edema, or sometimes other symptoms that may be right-sided heart failure symptoms, ascites, and renal and liver dysfunction, and may be confused with tricuspid regurgitation may not be identified as the driving force for some of these things. So it's something to keep in mind if an echocardiogram is done, that this is not just something that we kind of ignore. Okay, so the basics of the tricuspid valve anatomy, and as I go through my talk here, you will see this person, Rebecca Hahn's name throughout the talk. She is the founding matriarch of tricuspid valve disease and morphology and assessment, and a brilliant echocardiographer based in the United States. So a lot of the things I'll be showing you are things that she has published and pioneered. So first, we just look at the tricuspid valve. It's called the tricuspid valve because traditionally we've said there's a septal, anterior, and posterior leaflets. It's tricuspid. And you see here that there are papillary muscles associated with the tricuspid valve, typically 3 papillary muscles, but actually there may be 2 papillary muscles or sort of other additional variants. There are differences between the tricuspid valve and the mitral valve, in addition to it being traditionally 3 cusps and 2 cusps. The way that the chordae attach to the leaflets varies versus on the mitral valve, where they come off kind of directly from the papillary muscles, and you have the chordae attaching to the leaflets. The tricuspid valve, there can be more complex connections, particularly in the commissures, and you can also have connections directly to the RV wall as opposed to going through the papillary muscles directly. And so this can be very complex in terms of both understanding the anatomy, but it is important in terms of intervention. And as you've heard, I do interventional echocardiography. And so some of the comments I have a little bit of an interventional echo slant as we speak here, but I'll put in some pearls related to that. So, when dealing with the tricuspid valve, there is propensity towards being able to get caught into chordae, which may be higher in many instances compared to what you would expect with the mitral valve now. So this is the traditional kind of look that we look at if we're looking down on the tricuspid valve. I'll say this is when we're looking at it here, this is the mitral tricuspid aortic valve here. And, things are sometimes shown in terms of this orientation. And typically we will reorient images from an interventional perspective and from a discussion perspective more into this orientation, where you have the aortic valve here at kind of 5 to 6 o'clock. And then that allows more of a view of the tricuspid valve that's in keeping with what you see on some of your echocardiographic views. So more of the typical transgastric orientation. And so although some sites will use this type of view, the one on the left, where the aortic valve is at 12 o'clock or sort of 11 o'clock for their procedures as well as their orientation, we typically will, at our site, will reorient our imaging into the picture on the right, which is more in keeping with what we see on the transgastric views and to be more consistent. And as well in the interventional labs, in our interventional lab, we also do this in order to make sure everyone's sort of speaking the same language and seeing the same pictures. Okay. The tricuspid valve anatomy is complex. So the annulus is non-planar and elliptical shaped. The posterior septal aspect is the most ventricular, and then the anteroseptal component is the most atrial. And so sometimes it's hard, often it's hard, depending on which kind of view you're looking at, to know exactly where you're looking at, which leaflets you're looking at, because depending on how you're angled, you may have different leaflets. And I'll kind of go through this as we look through the transthoracic and transesophageal views. As I said, the tricuspid leaflets are supported by the chordae tendineae and papillary muscles, and they typically have 2 to 3 papillary muscles, the largest being the anterior papillary muscle with chordae that support the anterior and posterior leaflets, and then the posterior papillary muscle that has cords to posterior and septal leaflets, and then a variable but small septal papillary muscle that sometimes doesn't exist. Also important to note from a procedural perspective is that there's the proximity to the AV node, which is located here. You can see my pointer. And so when I've sort of reoriented it here in terms of our typical view, but when procedures are being done on the tricuspid valve, particularly TTVRs, it is quite in proximity to the AV node, which is why there's a risk of complete heart block after procedures. And patients are often kept in hospital for monitoring for several days thereafter to ensure that this doesn't occur. And it can occur in the acute period immediately during the procedure, but can also occur up to, in some cases, 5 days or longer after a procedure is completed. So I'm just going to go on now to talk a little bit again, another Rebecca Hahn paper here, looking at the standard echocardiographic tricuspid valve nomenclature. So when we are naming the leaflets, so, I said that there are typically, we call it the tricuspid valve because there are 3 leaflets, but in fact, more commonly than not, there are actually different orientations of the tricuspid valve that don't have 3 leaflets. So I'll go to this slide here for a moment. And so you can see here in 54% of the population, you have type 1, which is the typical septal anterior and posterior leaflet. But in the rest of the 50% of the patients, or just under 50%, the morphology of the anatomy is different. And so you can have a fused anterior and posterior leaflet where it functionally acts all as one leaflet and just one septal leaflet. This looks kind of like a mitral valve, but turned on its side. And then you can also have other morphologies where you have one anterior and 2 posterior, or 1 posterior and 2 anteriors, or 2 septal leaflets, or getting even more complex to 2 septal, 1 septal, 2 posterior, 2 anterior, or a variety of other combinations thereafter. So just to kind of explain how we decide what leaflets we have. So first, the leaflets are defined. We look at the picture and we look at, is there independent motion from the adjacent leaflet? So is this truly a leaflet versus just a scallop? And then is there color extending into the region sort of in between what we call the commissures? Then the commissures are identified. So the anteroseptal commissure is identified, and then the interventricular septum is identified, and then the most anterior papillary muscle is identified. And so sometimes you have to use multiple views in order to figure that out. Sort of like looking more into the RV, it is sort of deeper, not the leaflet tips. And then once these structures are identified, then you can decide which of the different anatomies you have. So I'm just going to go back to this image here. So you have the septum, the anteroseptal commissure, and this little blue dot, which is the anterior papillary muscle. And then based on where the leaflets lie relative to this is how they're named. So if they're attached to the interventricular septum, then they're called septal leaflets. And then from the anterior septal commissure over to the anterior papillary muscle, any leaflets that are there are considered anterior leaflets. It would be A1, A2. And anything posterior to the anterior papillary muscle and between that and the posterior septal commissure are considered posterior leaflets. And so that's why in this situation, you would count these as 2 posterior leaflets, but in this situation, you would count this as 2 anterior leaflets. So just from a nomenclature perspective, that's sort of how it's named. And so I've kind of explained that here on the right-hand side. But if we look, so we see here, you see we have defined the anterior septal commissure, the interventricular septum, and the anterior papillary muscle based on other views. And so then you have the leaflets, which this is continuously. But in the top picture here, you have like the 3 that you can see here, septal, anterior, and posterior. And then in the picture down here on the bottom, you see more of a 4 leaflet morphology. And again, based on where your anterior papillary muscle is, then we say this one has 2 posteriors versus 2 anteriors. Does that make sense? Is there any questions for that? We talked about this too already. So then you could also have complex things where you have, Barlow's types valves, and then you're not really sure how many leaflets and how many cusps you have. But again, if you try to use the algorithm that we used, you would say that there may be lots of scallops, even though there's only a certain number of cusps, a certain number of leaflets. Okay, and why do we even care about this? We made this complicated system, and what's the usefulness of that? Well, part of it is to make sure that we're having consistent naming of things and nomenclature, so that when we're speaking to each other, we understand what we're saying. But it's also because this is important in terms of when we're describing the leaflets and the location of the jets. And it's important because if we're intervening, T-tier has been shown, which is tricuspid edge-to-edge repair, has been shown to be more successful in type 1 morphology where there's just 3 leaflets. And as you get to more complex morphologies, the procedural success rates do go down. But it's also important from procedural planning perspective because anteroseptal jets are the easiest to deal with, and then posteroseptal jets less so, and then jets between the anterior and the posterior leaflet generally are not amenable to tier, and we need to look at other options. So being able to name the leaflets correctly and then identify where the color is coming from is important. So again, here the jet matters. So look at, this is the glide score, and then we also have the tri-score. The location of the jet is one of the main deciding, contributing factors in terms of determining the success. Okay. In terms of the components of the tricuspid valve evaluation on echocardiography, we'll talk about some components of this. So we discussed some of the morphology already, but we'll talk about tricuspid valve pathology and the mechanism of whether it's TR or TS. Tricuspid regurgitation severity. We also will look at the gradient for both the tricuspid stenosis perspective, as well as if we're planning on doing any interventions. And then the parts that we're not going to talk about today, but are very important in terms of your echo evaluation of the tricuspid valve, include looking if there's any pulmonary hypertension, and that's both looking at the RVSP as well as indirect measures of pulmonary hypertension, evaluation of the RV size and systolic function, and then identification of pacemaker and ICD leads, and then evaluation if there's any impingement. So we will talk a little bit about that later. In terms of TEE, we look at all of the above, but we'll look at the morphology in more detail, the parts that we kind of talked about a little bit already, but also assessing for any intracardiac thrombus or masses and vegetations. And then also this can be used for procedural guidance and planning. In addition, we do have ICE that's available, and I'll show a couple of pictures just out of interest in terms of procedural guidance, in terms of evaluating the tricuspid valve. Other imaging modalities that might be used adjunctively to help you for your tricuspid valve include CT scan. So that can be used, for example, in the context of tricuspid tier. If there is a pacemaker lead with impingement and you're trying to analyze that, you're not completely clear from the echo. Also for TTVR planning, both for looking at the annulus, the RV morphology, and for planning of the procedure. And then cardiac MRI is important as well. It may not be available at all of the centers that you work at, but it is the gold standard for RV size and systolic function assessment. And so especially in the context of if it's not clear from the transthoracic images, it may be worthwhile, or if you need better quantification, to consider a cardiac MRI from that perspective. And I'm not going to talk about sort of the right heart other parts of the right heart assessment here today, sort of outside of the scope of what we have time for in this 1 hour. Okay, I'm going to go now through the different views of the tricuspid valve on transthoracic and some tips and tricks to help us know which leaflets we're looking at, which views. Because like we said, the tricuspid valve annulus and the tricuspid valve leaflets don't sit all on one plane. And so depending how you're cutting the valve, you may have different leaflets being visualized. And again, these are lovely pictures from also that paper from Rebecca Hahn. She just put her name on my talk, I suppose. So these are nice because we're able to see how we're cutting through the structures and then which plane we have in terms of the view. So this is your typical peristernal long axis view. And then sort of as you tilt and you see the coronary sinus, so you see the coronary sinus here and the interventricular septum, well, then you know that the yellow leaflet here, the leaflet that's closest to the septum, is the septal leaflet. And then in this view, the leaflet that you'll be seeing opposite to that would be the anterior leaflet. If you are not seeing those structures, then typically you're not seeing the septal leaflet. You're actually seeing this being the anterior leaflet, because that's where the probe is, and then the posterior leaflet. So, you know, if you're in the traditional view, that's what you would see. But then when you start to tilt towards the coronary sinus and the septum, then you'll start to see the septal leaflet. Okay, and then this is now the short axis here of the aortic valve level on the left. So sometimes it looks kind of like it's all one leaflet. And when it's that, it's typically the anterior leaflet, which is adjacent to the aortic valve. Clues are that whenever you see the aortic valve, that leaflet's adjacent to that is always going to be the anterior leaflet. If you're seeing the septum or some of those other structures, then of course that's always going to be the septal leaflet. But if you don't have those structures, and you know what the opposite leaflet is often what we're kind of sometimes easily confused by. So if we look here, as the annulus dilates, you get sort of, instead of just seeing the anterior leaflet, then you start to see the anterior, and then also you start to see the posterior leaflet. And then you can tilt sort of below the aortic valve here towards towards the LVOT. Then you start to capture both the anterior leaflet, the posterior leaflet, and the septal leaflet, all three of the leaflets. So here, remember the septal leaflet, anterior leaflet, posterior leaflet. So we're starting to capture that as we go into the LVOT and start to sort of get towards the septum. Any other questions? Okay. So now if we go over and we look at sort of our four-chamber view, if we sort of, here we have our depiction, so you can kind of see where the lines are for the A, B line, which is your typical kind of more traditional four-chamber view. And in that view, the leaflet that's next to the septum is always going to be the septal leaflet. But then the leaflet that's not next to the septum is called lateral leaflets, because it could be the anterior or the posterior, depending on what you're seeing. And if you start to angle again to where you're seeing the LVOT, so angle up sort of anteriorly, then you're going to be seeing the septal leaflet again next to interventricular septum, but the other leaflet you're going to see is the anterior leaflet. Versus if you start to angle posteriorly, where you're starting to see the coronary sinus, then you're going to see again the septal leaflet, but you're going to see the posterior leaflet. That makes sense? Questions from that? And then on TEE, we're fortunate that you're able to, some views actually see all of the leaflets. So we'll start off here with the mid-esophageal views, where you see the aortic valve. So if this is the aortic valve, the leaflet next to the aortic valve is which leaflet? Anterior. Great. I got one of my objectives through. And then the opposite leaflet here is the posterior leaflet. And then as you cut through this at different, you will see on your X plane at 90 degrees to that. So if you're cutting through the posterior leaflet, then your posterior leaflet here is going to be on the right. And then your septal leaflet is going to be on the left. And if you cut through the anterior leaflet, in the same way on your 90-degree view, on the right, you're going to see the anterior leaflet, and then you're going to see the septal leaflet. Okay? And so typically, I'll show, I think I have the later slides here, but where we'll do some valve mapping. But this is what we talk about when we're valve mapping, like going through and kind of systematically starting commissurally and going through the posterior septal commissure, and then more centrally posterior septal, and then central anteroseptal, and then sort of more commissal anteroseptal, and trying to do both 2D and color in order to understand the anatomy as well as the location of the jets. And then this is really nice because it gives us the grasping view. And so from a procedural planning perspective, being able to know where the jets are and what the morphology looks like on the grasping view, and if there's adequate leaflet there, are there a lot of cords in the way, things like that is very helpful in terms of procedural planning as well as procedural guidance. So here's some examples here. We have some transgastric views. And again, so there's the sort of lower view here where we're able to see the anterior papillary muscle, and then sort of coming up to the leaflet level where we can now see the leaflet tips, and then putting on the color so that we can look at where the color is going, both in terms of regurgitation, but also in terms of sort of identifying the leaflets from a morphology perspective that we talked about earlier. So often these are the kind of initial views we'll do to look at the morphology and to look at the color in terms of identifying different leaflet morphologies, and also evaluating the regurgitation. So now we're also in the esophageal views. You have sort of the deep esophageal views and the sort of mid-esophageal views.
Just favorite.
The deep esophageal view. Okay, we'll talk about that one later. But you can see here the aortic valve here, and so therefore this is the anterior leaflet, and then this is the posterior leaflet. We're coming down to sort of get to sort of, we're not quite in that the tricommissural view, call it that, but just in terms of like looking at this picture here, what are we seeing as the major pathology for this tricuspid regurgitation?
Prolapse.
Yeah, prolapse, exactly right. So you can see the prolapse of the anterior leaflet quite nicely here. Thank you for participating. I appreciate it. And we were talking about mapping here. So, so this is where we talk about going through and doing sort of a very careful explain, and then I'm not sure why they're not playing continuously, but where you will explain and then without color, without moving your cursor, so you can see what the anatomy is like at the location of the regurgitation. Then you can continue to do that sort of now as you go sort of more centrally here, and then again you put the color on, and then see where the color jet is coming from, and then again we can go a little bit more anteroseptal. Again, 2D and color. And then we can repeat essentially the same on all of our views here. So we, again, could do this in the mid-esophageal views, where we're sort of more like the typical that we saw earlier. Again, looking at the posterior septal commissure sort of more centrally, and then anteroseptally at both 2D and color. And then we will, in the era of 3D, we will be doing 3D on all of these patients, both from an understanding of the anatomy perspective better, as well as in terms of looking at all of the structures and the function, and this can be done with and without color. And it's also helpful in terms of aligning things, and if we aren't able to get our mid-esophageal view kind of nice and flat so that we're explaining through it directly with our cursor up and down, we can create a 3D kind of data set and then interrogate the valve in a similar kind of way, creating our typical bicom view with our explanative, and then our transgastric view, which is the only view where you're able to see on transthoracic or transesophageal echo all of the leaflets simultaneously. But if we don't have a good transgastric view, we can recreate that here from the mid-esophageal windows. And then similarly, I'll show you later where if you don't have good esophageal windows, you can recreate similar windows using your transgastric views. And we can use this again for interrogating the valve in detail, looking at sort of, you can move your cursors along here, depending on where you want to, what pathology you want to be looking at, and try to look at, as we're seeing the equivalent of the grasping view, like what does the leaflet look like? Are there chordae, like this thick cord that's here? Maybe that's not going to be getting in the way because it's not quite at the leaflet tips. But we want to be aware of it when we're doing any procedures and sort of planning things in terms of interventions. And then here is a transgastric view where we start transgastric picture here. And then you're able to build your 3D views off the transgastric. So instead of the transgastric, the 3D picture being built off of the image here, which was transgastric, this is the looked like a transgastric, but was built out of the esophageal views. You start with the transgastric view, and then you can align your planes so that you get the views that you want. This one is sort of upside down, if you want to call it that. That's how it shows up when you first initially create it. And if you're not comfortable looking at it that way, you can actually adjust it on the machine so that you can rotate. You select the blue box and then use your rotate Z-axis, the same way you would rotate your 3D image normally in order to rotate that 180 degrees so it's upright, if that's easier for you to see it that way. Again, the same thing with color. And this allows you to have some flexibility in terms of looking at the valve in terms of multiple different views and building your 3Ds, regardless of what your best window would be. Okay, we're going to spend a little bit more time now just talking about tricuspid regurgitation and the different etiologies and assessment of tricuspid echo. So this was called sort of the new integrated classification. I won't say that it's necessarily new, but it is a sort of a different sort of nomenclature than maybe you thought about before. So on the mitral side, we often talk about primary and secondary. Then on the tricuspid side, there's also the addition of the lead-related tricuspid regurgitation, which is not a small, if not an insignificant amount of tricuspid regurgitation etiology. And the management of that is different, and it impacts the selection of intervention. So it's important to identify if there's involvement in that perspective. Primary tricuspid regurgitation, so that's things including myxomatous disease, like the prolapse patient that we saw, carcinoid, rheumatic, other sort of potential post-pacemaker lead removal related tricuspid regurgitation would belong to that category. And then under the functional or the secondary tricuspid regurgitation, it's important to try to identify whether the patients have atrial or ventricular functional. We kind of sometimes just say functional, but the prognosis for these patients is quite different. The atrial functional patients do a lot better than the ventricular functional patients. And we would still treat all of these patients, optimize them medically and look for all the other potential etiologies that we can treat prior to sort of going forward with intervention, but it may also impact some of what we select. So just to understand here, so from this, these are the same sort of categories that we already talked about here in terms of the morphology of what you expect. So this is the lead-related one. That's sort of the obvious one where you can have the leads impinging on the leaflets themselves or the subvalvular apparatus, or sometimes you can have leads, and of course they're just bystanders, and so important to sort of identify whether it's actually implicated in the pathology of the tricuspid regurgitation or not. Atrial functional patients typically have more significant atrial dilatation, the most significant part being the atrial dilatation. They may also have some ventricular remodeling in the context of chronicity of their tricuspid regurgitation and the volume overload, but typically it's an atrial predominant problem versus this ventricular kind of predominant problem. So the leaflet restriction typically in ventricular functional occurs during systole, and there tends to be apical tethering of the leaflets versus in atrial functional, it tends to be more of a flat coaptation. Let me give you another example. So if we look at these examples, so A being normal, so B, which type would this be? Primary, atrial functional, or ventricular functional? There's no lead, so there's no like hiding lead in this picture. So, so this one you can see here, like this is the annulus here, and you have like this cord which is disconnected here, and then now this leaflet is prolapsing back, and this cord is torn. So it's a leaflet / supporting apparatus problem. So this is we consider primary. And then here you have two different examples of functional. So here you have where the atria is quite dilated, and you can see you have a flat coaptation. And the ventricle is also a little bit dilated, but this is more of the atrial functional. And then here, this is more a good example of the ventricular functional, where you have typically the posterior leaflet tends to be a little bit more tethered, but it can be any of the leaflets that's tethered, and usually both multiple leaflets are tethered. And then you can see it's more related to ventricular remodeling. Although again, you can also have atrial dilatation. So important to try to see if you can understand what the mechanism is, and looking at how the leaflets lie kind of helps you with that. So here's an example. Now this is a non-moving image, just so I can kind of show you an example here again, and then I'm going to show you some moving images. So you can see here the atria are big, the ventricles are not so big. This is an example of atrial functional versus the ventricular functional, where you see the leaflets are more kind of like tethered up here, and you see this the ventricular dilatation here, as well as there is some atrial dilatation as well. Okay, so we're going to go through some examples here. So example 1.
Atrial?
Yeah, so this is like an atrial functional. You see the RV is not that big, but the atria are quite large, and you can see kind of the flat coaptation line there. Good. And I'm going to show some more pictures for this example. So we have a lead here that's kind of in the middle. And we're going to put aside this little part here that is not part of the discussion point right now, but to note that we didn't just ignore that in this patient. But we do have a wire here, and then the atria are quite big. There may actually be a little bit of prolapse as well here. So this is, probably multiple mechanisms. There's definitely some prolapse here, but that's not the entire component of what's going on. Also, you can see here that you do have some leaflet interaction with the pacemaker lead, and you're getting quite a bit of color coming from that. And then there's also quite a bit of atrial dilatation, so you are getting some part of the leaflets as well. So this is kind of a bit more of a mixed etiology.
Yeah. There's something that's probably a bit tethered as well, but the body does kind of feel a little more into the right atrium. Because the jet's directed towards the septum.
Okay, and then how about this? It may be a bit harder to I didn't show you all of the different pictures here, and I didn't show you, but you can see a little bit on the X-linked here. But this is an example, and I actually have more pictures of the same patient later, actually, so maybe we'll next slide that had that. It's not there, but we'll get back to that one as I'm showing you more pictures later on. Okay, and then here again, we have another pacemaker lead example where you have a pacemaker lead going through, and then what is the pacemaker lead a bystander? Is it involved? Involved or bystander?
Can you play it again?
Yes.
Not partially full.
Sorry?
Full.
Yeah. And you can see here, even though, you can see right here as it goes through the subvalvular apparatus here, it actually looks like it's almost like stuck to it, kind of going through the subvalvular apparatus.
The leaflets are also quite tethered in the training. It's interaction with.
Absolutely. And here you can see the interaction with the leaflets and then the tethering. And then also part of this tethering, I think, is because of ventricular remodeling, but also part of it is that this pacemaker lead is going through and further tethering the subvalvular apparatus kind of down.
That's a good example of how, at the end stage, there's usually multiple components. It's difficult to sort out. It's a vicious cycle, like I said.
Okay, and then this one, which I was trying to find an example from one of my cases for this, and I had to use a YouTube one, but it looks the same whether I'm playing it or not in terms of the leaflet motion.
Yeah, I don't think you need to call it.
Yeah. And so thoughts, the diagnosis that's screaming out at you here. Yes, exactly. And so typically you have that fixed leaflets, and you can see as Dr. Leoncoy says, you don't even need the color to know that it's wide open here. I'll just play it again just so that we can see it one time. Okay. So now we'll talk a little bit about tricuspid regurgitation and the grading system. And again, Dr. Hahn's name appears as we talk about this in detail. So the tricuspid valve severity grading system typically included mild, moderate, and severe. And various different features of the valve were incorporated. These are like ESC guidelines. Various features were incorporated, and like the ESC guidelines as we sort of go through. But the various features that were incorporated are still relevant now, although the grading system has changed. So I'll just kind of talk a little bit about some of these things. So in terms of severe, looking at the tricuspid valve morphology, kind of like on the mitral side, if you have, a flail leaflet, ruptured papillary muscle, all of those kinds of large perforation or vegetation, sort of more in keeping with the severe realm. Also then, if you see the flow convergence, like on the last case that we looked at, which was large and going through throughout systole, and also that sort of to and fro kind of flow, we see that as very severe and kind of like laminar flow almost. And in those situations, if you're trying to look at the pulmonary hypertension, it will not be an accurate assessment if you're just looking at the RDSP. In addition, there are additional parameters, so things like looking at the denseness of the jet, adjunctive parameters like the IVC diameter, the jet area, vena contracta, PISA, and then hepatic vein flow. So I'm going to talk about some of these in a little bit more detail, as well as some of these quantitative parameters. Okay. So there is this criteria that used to be used. I'm calling this as part of the classic system, where they said, some of these diagnostic criteria for severe tricuspid regurgitation were like dilated IVC and a large RA without additional causes for that, a large jet area and vena contracta width, and then the systolic reversal of hepatic veins. And then this is the dense triangular jet that we kind of talked about. These are the more quantitative parameters that we use kind of on a more regular basis now to try to quantify things a bit better in terms of both looking at the PISA, the 3D color Doppler, as well as some quantitative Doppler parameters that can be used as an alternative when PISA is not available in terms of looking at the regurgitative volume. And so I'm going to talk about PISA and 3D color Doppler in a moment. But when you don't have those options, you can also use additional quantitative Doppler parameters by looking at the diastolic, looking at the regurgitant volume by looking at the diastolic stroke volume and then the forward stroke volume. And so the total stroke volume, which is like the actual difference between systole and diastole, can be looked at, in a variety of different ways. You can look at it sort of by biplane parameters. You can have used a 3D other parameters to get sort of volumes in terms of that, and then also looking at sort of your additional flow parameters by looking at the tricuspid valve VTI with the PW at that location, and then doing some basic math. But we can also, more typically we would use the PISA radius if that's the PISA method if that was available. So this is sort of a newer classification system, and I say it's newer, but it's actually since 2019. So it's not really that new, but we actually have more different classifications. There's mild, moderate, severe, massive, and torrential. And this sort of summarizes the main parameters, so that I'll talk about in a little bit more detail: vena contracta, EROA, and then 3D vena contracta area. So here's an example of a PISA that we all know how to do here. So you adjust your alias velocity in the direction of the jet. You measure from the narrowest portion to the color change between blue and yellow. Typically, you will then get a CW jet through the tricuspid regurgitation and then trace that in order to get both your VTI as well as to get your max velocity that you need in order to calculate both the ERO A as well as the regurgitant volume using this kind of calculation, which nobody does by hand, but you can use a variety of different calculators. And this is sort of just what we talked about, so aligning jet, zooming your picture to get a better ability to measure accurately, and then considering angle correction if you're not able to get aligned. You can also use other, try to use as many views as you can in order to get the PISA, because you may not be aligned in one view, but you might be aligned in another view. And then the same thing with the jet for the CW, especially with these eccentric jets. Sometimes you have to use off-axis imaging in order to align with the jet. Limitations to this. So if there are multiple PISAs, obviously you're want to make sure that you're going to try to use the largest PISA typically. But it does get, the PISA does underestimate the severity if there are multiple jets, and it overestimates the severity if it's not hollow systolic regurgitation, as well as if it's not hemispheric. So in the context of functional tricuspid regurgitation, typically tends to be a non-hemispheric jet, and so often it's underestimated in that situation. Vena contracta that they suggest is not just typically a one-dimensional vena contracta, but actually vena contracta in two different dimensions, and then an average taken of those. So like if we look up here, this is the biplane average that they use in terms of the severity classification. And so here they have the inflow view and then an apical four-chamber view, and then kind of doing an average of those two vena contractas. Again, similar limitations to the PISA. If you have multiple jets, it's underestimated, it's overestimated, it's non-hollow systolic. And then you can try to do, like, as I said, different views and sort of more specific sort of off-axis views in order to try to get aligned. Jet area tends to not be as useful because it's dependent on a lot of pressure parameters and not just the EROA and also consultancy. So we don't rely on that as much. And then this is just an example of the 3D vena contracta area. So you get your 3D image, you turn the color on, then you get aligned, and this is not good. But luckily we only have a few minutes left, so hopefully we should be okay. But we will, and then you align with your vena contracta area and then freeze your image, and I'll show on the next picture here and then you kind of trace the ALVs to color. Again, not as useful if you have multiple jets because it can be time consuming because you have to add each separate jet. Okay, in terms of the additional parameters, we have hepatic vein flow reversal, which indicates significant but can be affected by other components. So it's not always just, we used to say this shows that it's severe, but it can be affected by RA compliance and arrhythmias and other things. The density of the jet, just sort of qualitative and subjective, so we don't use that as much, but definitely the triangulation of the jet is helpful as well. Okay. And then I talked a little bit about the additional parameters here. So again, you can calculate the regurgitant volume, use additional methods. If your PISA is not helpful, you again calculate the forward stroke volume and then the regurgitant volume by taking the diastolic stroke volume and subtracting the forward stroke volume. And you can use the forward stroke volume either from the RV or the LV side, assuming that there's no shunt. Okay, I will just go on to say that in terms of special considerations, we would want to look at things like the pacer wire. Again, is it involved or is it a bystander? Jet location, because the jet location is important in terms of determining the success of procedures, and the gaps measured in the grasping view type view, not like, for example, looking at the AP gap if we're going to be not putting a clip there. And then just in terms of imaging quality, I'll talk about that for a couple minutes here. So here, this is an example of the pacer that's interacting with the subvalvular apparatus there. We looked at that one earlier. Another one here where it's interacting with the leaflets themselves. You can see there's quite a lot of color sort of associated with that. Let people look at that for a moment. And then you can have bystander pacemakers, which are particularly when they're tucked into the PS column, they're kind of out of the way. They're not involved in where the color is. So here the color is, here the AS column. This pacemaker is kind of tucked away here. There's not a lot of color coming from directly there. So we can sort of go on to do intervention. Let's say if we think that the color is located here and we want to put a clip or a tier device at the AS column, we could do that. But sometimes, even when they're just bystanders, they're in the way of the procedure, and they can be snared in that situation out of the way and then potentially kind of moved so that a device can be placed the location that you want. But